Welcome back to the health module for our heart health interpretations and interventions. For this section of the heart health module, we'll be moving into cardiac remodeling and hypertension as they are interrelated. This will definitely be focusing on our most severe side effect and one that is most acute in occurrence and could be the point of where we see early deaths in bodybuilding from this specific reason. So this is by far one of the most important lectures to pay attention to for a harm reduction standpoint. In this lecture, we're going to cover what is cardiomyopathy, put a few definitions in place. What is the risk for actual heart remodeling for the steroid user? We'll look over the pathophysiology of how this actually occurs. Then also tie in the role of hypertension and what we should do to accurately assess it. Then we're going to follow through with our interventions for lifestyle, nutrition, supplementation, and then getting also into the pharmaceutical side for some understanding of which drugs might be best for a bodybuilder with some specific focus on telmisartan and also nebivolol. We'll also get into cardiomyopathy, the medical interventions, so we have some understanding and basis for what our practitioners and physicians will be doing for this type of issue. And lastly, we're also going to look at monitoring resting heart rate, as this might be a good potential prophylactic strategy to managing cardiac remodeling. Then finally, just getting into an overview of monitoring this risks and what we should really focus on overall for heart function for the future PD user. So back to our what is the issue slide. We've seen this before. We've gone through thrombosis. We've gone through atherosclerosis. Now, finally, we're arriving with hypertension. We'll get into these main mechanisms that really drive this issue. Then also cardiomyopathy, more particularly looking at left ventricular hypertrophy, as this is one of the main remodeling aspects around a steroid user, where we not only see remodeling, but also dysfunction in the heart as well. So looking through our similar graphic we've already addressed the left side of this. We're now getting into the right side aspect where we see steroids having a direct toxic effect, binding to the androgen receptors on cardiac tissue, increasing oxidative stress. We also have renin-angiotensin-aldosterone system increasing and activation, driving up blood pressure, not only causing stress in the kidneys, which will be some of the next lectures to come, but also to the heart, putting more strain onto the heart and why some of this remodeling is occurring. And through this remodeling and renin-angiotensin-aldosterone system and also direct effect of steroids, we can have collagen concentration increasing the heart, causing cardiac fibrosis, leading to less elasticity of this cardiac muscle, less efficiency in pumping out blood, and all this causes thickening of the heart walls, that type of changing, leading to cardiomyopathy. So that was a really quick rundown, but we should probably break down some of these definitions and looking a little bit more at the heart so you have a baseline understanding of when we get into the studies of steroid users, what do these terminologies mean, and just give it a picture to the things that we'll be describing. So on the left side here, what you'll see is a normal heart, which we have two atriums, right atrium, which leads down to the right ventricle. Now this is blood flow that is returning to the heart, and this side of the heart will pump blood to the lungs. So we'll have pulmonary arteries running, and that blood will get returned through the left atrium, and it'll go to the left ventricle, and that ventricle will contract, and that will push blood throughout the rest of the body. So we see as deoxygenated blood coming into the heart, going to the lungs to get oxygenated, back to the heart, and then pumped to the rest of the body to deliver this oxygenated blood. Now, what can happen with a dysfunctional heart and one that is getting exposed to the steroids over time is that these steroids lead to concentric left ventricular hypertrophy, as signified by an increase in left ventricular posterior wall and interventricular septum thickness. So what we see here in this left ventricle is that this posterior wall starts thickening, and also this interventricular septum along here also thickens for a few different reasons that we're going to address here further. Additionally, the ejection fraction, which we're going to define this as well, we simply say for right now, the ability for this heart to pump blood out is declining. So we see left ejection fraction decrease. And the ejection fraction here is the amount of blood pumped out divided by the amount of blood in the chamber. So we're seeing a lot of blood left in the chamber and not a lot to be able to pump out. This means this ventricle is not very efficient in doing so. We're not getting a lot of blood flow to the rest of the body. Now, a normal ejection fraction, this is how we can really look at the severity of cardiomyopathy, is a normal ejection fraction is 50 to 70%. You might see this at 52 to 72%. That's what's in our image, so, but pretty close around this range. Now, when you have borderline issues, it could be 41 to 49%. And we have finally like very much reduced cardiac function, less than 40%. Now, a note here is that higher is not necessarily always better, as a high ejection fraction of over 75% can actually indicate hypertrophic cardiomyopathy as well. So we might have so we might have an accommodation to starting to have some left ventricular changes where this heart can actually pump harder and actually push more blood out. And this might be even problematic as well. So we'll need some very further testing to be able to done, looking at more than just this image here. Of course, having the testing that we're going to go into further for what type of evaluation you might need to really see what your heart functions at. Now, why this is important is left ventricular hypertrophy is an independent risk factor for sudden cardiac death. This is why we see some of these immediate, like sudden deaths in these young individuals that's occurring. This is so important to know.